Hello everybody, it's my pleasure to be with you in this preceptorship. It will be the anti-VEGF, the anterior segment point of view. Actually, this is the look of any cataract surgeon when he discovers that his patient has cataract. A big smile will appear on his face. However, some cases carry some surprises. These patients are old and they carry the risk of AMD, diabetic macular edema, and other conditions that may necessitate treatment before going to cataract surgery. Both cataract and AMD are common cause of poor vision in elderly. They often occur together in people over the age of 50. In patients with stable preoperative fluid on OCT, cataract surgery is both safe and effective. No worsening of the neovascular process occurred due to cataract itself. If you have a patient who will undergo cataract surgery in the future, you have to advise him, if he has dry type of AMD, that he has a lesion in his macula and the expectation for vision is less than a patient who have no AMD. But if the patient has wet type of AMD, you have to treat him first and get rid of all the fluid before you go to cataract surgery. So the golden rule is to operate when dry as much as you can. The cataract surgery was beneficial in patients previously treated with anti-VEGF for exudative AMD. Surgery should be performed after a sufficiently long exudation-free period to minimize exudation recurrence. The other condition that may necessitate injection before cataract surgery is diabetic macular edema. An analysis of 4,850 eyes, and you can see here that 1,719 eyes with no apparent diabetic retinopathy, 1,034 with mild non-proliferative, 1,527 with moderate non-proliferative, 165 with severe non-proliferative, and 405 with proliferative diabetic retinopathy. The rate of DME requiring treatment spiked after the surgery. Peaking in the 3 to 6 month postoperative period occurred. Patients with moderate and severe non-proliferative diabetic retinopathy are at particularly high risk of diabetic macular edema. It was found that vascular endothelial growth factor increase after cataract surgery 10 times at day 1 and 2.5 folds at 1 month. Lead to diabetic macular edema and a poor vision after cataract surgery, which is the thing that you want to see in your patient postoperatively. Another important entity is the pseudophakic macular edema that occurs after cataract surgery. And there is always a mix between the diabetic macular edema and pseudophakic macular edema after cataract surgery. In this big study of 81,984 eyes, the instance of pseudophakic macular edema in eyes without operative complications, diabetes, the risk was like 1.17%. The relative risk was increased in eyes with capsule rupture with or without vitreous loss to 2.6%. The previous diagnosis of epiretinal membrane, the relative risk was 5.6, and in cases of uveitis, 2.8. In retinal vein occlusion, the risk rises to 4.4%. Retinal detachment, repair, the relative risk is 3.9. Patients with diabetes, even in the absence of retinopathy, had an increased relative risk of 1.8 of new macular edema after surgery. The risk was higher in the presence of any diabetic retinopathy. Relative risk is 6.23. So beware of patients with diabetic retinopathy. They develop more pseudophakic macular edema. This rose proportionately with increasing severity of diabetic retinopathy. So if the patient has severe diabetic retinopathy, expect more macular edema. How can we differentiate between the pseudophakic macular edema from diabetic macular edema? We can differentiate easily with the OCT. The spectral domain OCT tells us where is the edema. If the edema is in the inner layers, this is pseudophakic macular edema. If it is in the outer layers, it is diabetic macular edema, especially if we find cysts in the Henle layer. So it's very easy to differentiate between the two sides, especially if you find hard exudates, if you find capillary non-perfusion, if you find other manifestations of diabetic retinopathy, you can differentiate easily between the two conditions. So here is the differentiating points between diabetic macular edema versus pseudophakic macular edema. In diabetic macular edema, the representative central line scan has a central macular edema pattern, mainly cysts in the Henle layer, hard exudates, microfoci, and disruption of the photoreceptor layer, while in pseudophakic macular edema, there is a subretinal fluid, usually, intact hyperreflected band, and sometimes there is the mixed type where it represents both pseudophakic as well as diabetic macular edema. The OCT experts can tell you with a high confidence rate the difference between both diabetic and pseudophakic macular edema. We all know that we can treat macular edema, cystoid macular edema, in diabetic and non-diabetic patients with non-steroidal anti-inflammatory drugs. However, studies showed that short-term results suggest that intravitreal injection of anti-VEGF is safe and well tolerated in patients with pseudophakic cystoid macular edema. The treated eyes had a significant improvement in the best corrected visual acuity and decrease in macular thickness by OCT. So it is beneficial in post-operative period to give the patient with cystoid macular edema an anti-VEGF injection. Now comes the question, if I have a patient who is injecting anti-VEGF for diabetic macular edema, and his cataract got worse. Is it okay to do cataract surgery in between the injections or not? Actually, the studies showed that you can go for cataract surgery if you have good results with the anti-VEGF and there is deterioration of cataract during this period. There is an average gain of 2 lines of vision within 1 month following cataract surgery in these patients, and you can continue on anti-VEGF injections after the cataract surgery if the patient is still in need. Then comes the question, do I have to inject simultaneously during cataract surgery? And the studies showed that a combination of intravitreal injection of anti-VEGF along with phacoemulsification is beneficial for maximum visual rehabilitation in the first post-operative month. Then return to the pre-cataract surgery injection protocol that you are using with your patient. Please beware of diabetic patients who will undergo cataract surgery and have macular edema, because sometimes you will have a biometric error because of this macular edema, especially if you are using the ultrasound and not the optical biometry method. If you are obliged to use the ultrasound, like in such a condition of mature cataract, beware that you are measuring until the inner limiting the limiting membrane here. So you are not including the retina itself like in optical biometry. So you will find a shorter axial length that may cause an error of like 3/4 of a diopter. This study showed the difference between the A-scan ultrasound versus IOL master because the optical method is measuring until the not the internal limiting membrane, but to the end of the retina at the retinal pigment epithelial site. So it's better in such cases of macular edema to measure with the optical biometry method. The explanation. The contactless operation of optical biometry, which eliminates the confound of corneal applanation at axial length measurement, along with the difference in this picture between the ultrasound A-scan that measures till the internal limiting membrane, while the optical biometry measures until the retinal pigment epithelium. Every cataract surgeon should be aware of what's called the HORV, which is hemorrhagic occlusive retinal vasculitis, that occurs due to the use of vancomycin at the conclusion of surgery, especially in the other eye when you are using vancomycin in the first eye. You have to treat these conditions early with anti-VEGF, maybe along with laser, to prevent neovascularization and glaucoma. For cataract surgeons, the take-home messages are: Examine the retina thoroughly in every cataract patient, especially if you are going to do multifocal IOL. You have to do OCT routinely for these patients. Stabilize the retinal condition first. Let the retina to be dry before you operate. Use adjunctive drug when necessary. Thank you very much. I hope you enjoy the rest of the talks and see you. Bye-bye.